Just checking. Hamza, can you hear me?
Yeah, I can hear you.
Perfect. Shall I just do the introduction now, yeah?
Yeah.
Hello everyone, I hope you're all enjoying the weather. Welcome to our fourth Mind the Bleep webinar in our FY1 Survival Guide 10-part series. Today's talk breaks down discharge letters and specialty referrals, and it's going to be delivered by my colleague Dr. Hamza Duffaydar, who's an FY1 soon to be FY2 in the West Midlands. Just a reminder that this webinar will be recorded and uploaded to the Mind the Bleep YouTube channel as well as Medal. Please remember to ask questions in the chat and we'll make sure to answer them at the end. I'll also be available in the chat throughout the webinar to answer any questions. Remember, you can also sign up for free weekly webinars. I'll post a link in the chat. We'll also post a link for the feedback form in the chat at the end of the webinar, which will enable you to get a certificate of attendance for your portfolio. Without further ado, I'll hand over to Hamza.
Right. Thank you, Nihal. So as Nihal said, my name is Hamza. I'm one of the junior doctors working in the West Midlands. This talk today will be about discharge summaries and specialty referrals. So let's get started. So the content of the session today will speak about the importance of discharge summaries, the different components of a discharge summary. We'll also run through examples of discharge summaries, both good and bad, and we'll have a brief discussion about them. The second part of this talk will be about specialty referrals, and lastly, we'll summarize at the end. So discharge summaries. So we're going to talk about the importance of discharge summaries, but before we do that, we're going to talk about two terms which you'll hear quite a lot. So the difference between discharge summaries and TTO. So discharge summary is the main document which GPs and patients receive, and this will include a summary of what has happened in hospital. So that's the main part of your discharge summary, whereas TTO means to take out. TTO is usually the section following discharge summary, which includes any medication changes or any list of medications which the patient is on, both for the patient and for the GPs to be aware of. So usually TTOs they come off automatically following when you print a discharge summary. So why are discharge summaries important? So discharge summaries are the primary mode of communication between the hospital, which will be yourself in a few months' time, and aftercare providers. So that's usually GPs, district nurses, or anyone in the community who will be taking over the care of this patient. So through your discharge summary, you'll be able to tell the GP or anyone in the community what has happened to this patient, any changes to the management plan, any changes to the medication, or what's the future plan in terms of the care for this patient. Discharge summaries are also a good summary for the patient and their family members to receive about any events which happened in hospital or the management plan they received. So a lot of the time, some patients are quite elderly, or they might forget about things you've explained to them. So discharge summaries can serve as a good reminder for the family members or for themselves about the treatment they received in hospital. Lastly, discharge summaries are a good reference to have for past medical and past surgical history. A lot of the time, when you guys will be clerking in new patients, you can refer to previous discharge summaries for the same patient to know about the past medical history, to know about previous presenting complaints for this patient and what has been done for them in the past in the hospital. Because a lot of patients will often present with the same things that they've had over the last few years. So discharge summary is important to know how we have managed this patient in the past. So there are different components of a discharge summary. Usually it will depend on each trust, but across the UK, all trusts will use a software for discharge summaries, and this software will have different components. It will break it down, so it won't be one long document where you have to write all of it. You actually have different sections to fill in, but these sections are included here. So at the top, you'll have the patient identifiable details. So that's usually the patient's name, their date of birth, the hospital number, the NHS number, their GP name. This is usually automatically filled out from the software when you search up the patient. At the top, you'll have the reason for admission or the presenting complaint. So that's usually a few words about why the patient came in. It's not really too detailed. It's just one or two words about any symptoms they came into hospital with, what they were admitted with. Next, you have the diagnosis, so the provisional diagnosis you've reached. There might be instances where you discharge patients and you're not quite clear what the diagnosis was, but you write the provisional diagnosis at least. So it's really important to have a diagnosis for your GP and for your patient to be aware of as well, of what they were treated for in hospital. Another section of the discharge summary is coexisting medical conditions or past medical history. So usually it's quite important to list any past medical history this patient may have, because it could, as I mentioned earlier, you could use this discharge summary in the future when clocking in this patient. So that's why it's important to list all their past medical history. Only list relevant stuff. So I wouldn't really list, for instance, a patient had UTI in the year of 2011, in urinary tract infection. I would list stuff such as a patient had a STEMI in 2016 and had stents fitted. So that's relevant stuff. Another section of the discharge summary is investigations. In the investigation section, you'll usually mention any blood tests, any scan results, in this section. And following that, you have the procedures section of the discharge summary. So in procedures, you can include any operations they've had, the date of these operations as well. By operations, I mean surgical operations, or any other procedures such as chest drain inserted, paracentesis, colonoscopy, OGD, stuff like that. So that's useful to have in the procedures list, useful for the patient to remember and for the GP to know of as well. The clinical features is next. So the clinical features is a main bulk of your discharge summary. In the clinical features, you'll give a brief summary of why the patient came in, so their presenting complaint, how you manage this patient. You'll also include any investigations and what the follow-up plan is. So this, for instance, how you manage this patient, what medications you started them on, how they progress throughout their stay in hospital, and you usually write at the end, this patient was deemed fit for discharge. You also have a section about allergies for any medications. In this section, it's really important to remember that you should write any reactions to any medications. For instance, if a patient is allergic to penicillin, just say what do they have, what sort of reaction do they get when they take penicillin. So it could vary from a small rash to anaphylaxis, for instance. So this is important because in the future you can use this to know whether an allergy is actually an allergy or it's just a mild reaction. Other components of a discharge summary, you have the planned management notes. So in the planned management notes, so that's usually where you'll write the plan for any management in the community. For instance, this patient will be reviewed by district nurses to change their wound dressing, or they'll have an outpatient appointment with this specialty to follow up on this. So this is important because the patient is aware of any care that they will be receiving in the community. The GP is also aware of this, but also because ward clerks, when you print a discharge summary, they can use this section to book outpatient appointments with the consultants for this planned specialty. Another section is the information given to the patient section. So in this section, you can usually safety net the patient. So any red flag symptoms to watch out for and who to contact if they do have these symptoms. but also anything that you've told the patient and you want to remind them of. For instance, if someone has had an intervention and the legal requirement is not to drive for 1 week, so you would have verbally told the patient this, but just for legal purposes, it's good to inform, to write it in your discharge summary, but also to remind your patient as well about any information you could have given them. Lastly, you have any actions for the GP. So that's usually where you'll request GP to do any blood tests, review any medications, or anything that that you weren't able to do whilst in hospital, that the GP could follow up on. So I appreciate this sounds quite big, like all the different components of a discharge summary, but I'll run through a few examples and you'll see it's not actually that hard. So once you have this software to write your discharge summary, it's mostly just getting used to it. And yeah, so we'll run through a few examples to give you guys an idea. So what are the key points when writing a discharge summary? So remember, the key term is summary, so you don't want to write a long essay. A discharge summary should be written in around 15 to 30 minutes. Remember, you guys will be F1s in a few weeks or a few months' time. You'll have plenty of discharge summaries to write throughout the day. On top of that, you'll be busy doing ward jobs such as bloods, cannulas. You have to do ward rounds. So you have plenty of jobs to do. You can't spend all your time writing one discharge summary. So it's important for it to be concise. But that having been said, it should be concise, but should include the relevant information. And it should be easy to understand for the patient. Remember that your patient is going to receive a copy of this discharge summary. It's also important to know the fine balance, because the discharge summary is aimed both at the patient and for the GP. Because it's aimed at the patient, you don't want to include too many medical jargons in it. You want to keep it quite simple, but at the same time, because the GP will be receiving this as well, you don't want it to be too simple. So you don't want to use like too lay terms. For instance, if a patient had an NSTEMI, you can write Mr. X presented with an NSTEMI, because remember, your patients, they can Google a lot of the stuff, the medical terms. So yeah, it has to be simple, but it should also be medical because it's going to your GP as well. Avoid any abbreviations as far as possible, because this can be confusing for the patient. We'll run through a few examples, so you guys will see what I mean by examples of abbreviations. Again, your colleagues or the GP might not understand these abbreviations, so you want it to be as clear as possible. So discharge summary should be concise and relevant, only include relevant information. We don't want to know about a patient who's had, let's say, for instance, if they've had a fall and nothing has become of this fall. So yeah, so little things that have happened on the wards, we don't really want to know about it in the discharge summary. We only really want to know about stuff that will change our management plan. So if the patient has fallen, they've hit their head, they have a subarachnoid hemorrhage, then it's important to include it in a discharge summary. But if it's minor stuff, a minor rash a patient has developed on the ward which has been treated and is now gone, that's not important to include in your discharge summary. In your discharge summary, it's really important to explain the rationale for any medication changes so the GP can understand. Remember, your GP is going to look after your patient in the community. They are the ones who look after this patient there. So if you've made any changes to medication, it's important for them to know why. A lot of the times you get GPs writing, they actually write back to your consultants and say, why has this been started and stuff, whereas you can save this by just explaining it in your discharge summary. It's important to safety net your patient as well. So in the information to the patient section, write about any red flag symptoms the patient should watch out for and who to contact. And be courteous to the GP. Remember, GPs are basically consultants. So you as an F1, you can't really demand GP to do blood tests in a week, or GP to refer to cardiology. You can kindly request GPs, so be considerate in your choice of words when doing stuff, when asking GPs to do stuff. Again, try to do as most as you can in the hospital, because GPs don't have as many as many resources or access to resources as we do in hospitals. So try refer to specialities on discharge if you can, and even blood tests. Try print blood forms and give them to patients. But yeah, you can request GPs to do some stuff, but request it kindly, please. So now we're going to run through an example of a discharge summary. So the first example I've provided, this is a good example of a discharge summary. So this is how you guys should aim to write your discharge summaries. And then we'll run through some not so good examples as well. So at the top, you can see you have the patient name, their date of birth, and the address, so patient identifiable details. As I mentioned earlier, this the software you will be using will fill this out automatically, so you won't have to worry about filling this in. In the reason for admission section, as I said, only a few words about why the patient came in: chest pain. Because remember, in your clinical features, you'll describe more about the presenting complaint. So the reason for admission is just 1 or 2 symptoms why the patient came in. In the diagnosis section, the diagnosis which you and the consultant and the medical team or surgical team have reached for this patient. So for instance, NSTEMI. And I've included an abbreviation, but I've also explained it in here: non-ST elevated myocardial infarction. So that's for the patient to know as well. So if the patient wants to know what that is, they can quite easily use the internet or to find out what their diagnosis was. But obviously we would have explained it to them whilst they were in hospital. In terms of coexisting medical conditions, I've included a thorough list of their past medical history, but only if it's relevant, and the year, because that's quite useful. So as you can see, this patient had an NSTEMI in the year 2010. They have a history of hypertension, type 2 diabetes, and duodenal ulcer as well. So as I said, if someone is to refer back to this discharge summary to Clark, it's quite easy to get the past medical history from this discharge summary, as I've included all the past medical history in it. In the next section, the investigation section, I've included any relevant investigations which have been done. Because this is a cardiology patient, ECGs are important, and I've not gone on to write a massive essay about the findings of these investigations, nor have I gone to copy the reports of radiological reports. So just a brief summary, 1 or 2, 1 line should be enough. So for this patient, the ECG showed first-degree heart block. Their troponin, because they had an NSTEMI, it's important to record their troponin levels. So first troponin was 48, second troponin was 60. So there's been a rise in troponin. They had a low ferritin, which was discovered whilst in hospital. So I've included the results of the ferritin level for the GP to know as well. And all the other blood tests were normal. So I don't go on to list the normal blood tests. I just summarize it by saying all blood tests were normal. Chest x-ray was clear as well, was normal. So I just say chest x-ray was clear. And they had an echo whilst they were in hospital. So again, just 1 sentence summarizing the results of this echo. So mild aortic regurg, but normal systolic function. In the procedures section, I go on to list any procedures this patient might have had. So for this particular patient, they've had PCI, so percutaneous intervention. Again, I've included an abbreviation in brackets, but I go on to explain it in full for the patient's purpose. And so they've had PCI to the left anterior descending artery. So that's not really relevant to the patient, but it's relevant to the GP to know, because remember, GPs are medical as well, they're medical personnel. So it's important for the GP to know where this stent was fitted. And then the next section, so as I said previously, the bulk of your discharge summary will be your clinical features. So I refer to the patient by their name, Mr. or Mrs. X, presented to hospital with breathlessness and central chest pain on exertion. So that's the presenting complaint. He had an NSTEMI in 2011, and he describes his symptoms similar to his episode he had then. So I talk a bit about the past medical history, relevant past medical history, which is he had an NSTEMI, and his symptoms were similar to when he had an NSTEMI. I go on to speak about troponin levels being 44 and 60 on admission, and ECG showing first-degree heart block, but not showing any signs of ST elevation. So again, this is aimed at the GP. It's important for the GP to know the results of any interventions we did. All other blood tests were normal, chest X-ray was clear, and echo showed mild aortic regurg with normal systolic function. I next go on to tell the GP and the patient about the management plan we've started for this. We've initiated for this patient whilst in hospital. So we treated for acute coronary syndrome, and we referred them for PCI. And I go on to mention where this stent was inserted, so to the left anterior descending artery. So next I move on to my next slide. So this is a clinical features section continued. I go on to explain any changes to medication and why, the rationale why we've chosen a certain medication, not a lot, and not another. So as this patient could not tolerate atorvastatin at high dose, he was started on rosuvastatin instead and ezetimibe. So that's important for the GP to know, because in the future, if the GP was considering switching this patient over to atorvastatin, they can refer to my discharge summary and they'll know that this patient is not tolerating this medication, so the GP will find an alternative for it. I go on to say this patient was started on clopidogrel and dual antiplatelet therapy with aspirin, which he already takes for 1 year as per protocol for PCI. And then I talk about any relevant things that have happened to this patient whilst they were in hospital. So whilst in hospital, it was discovered that this patient had a low ferritin at 27. So I mentioned the blood test results, and I say we've discussed with the gastroenterologist who've agreed to see this patient in outpatient setting. So this lets the GP know that this patient's low ferritin will be followed up upon by the gastro team, and they'll decide on a treatment plan for it. It's important to say your patient was deemed medically fit for discharge because I know it's common sense that if you're discharging a patient, they're usually fit for discharge or they've come near the end of their treatment care. But it's important to mention it for the GP as well, just so they're aware of how this patient was just before you're about to discharge them. And I go on to mention any outpatient tests we've organized for this patient. So this patient, for instance, will have 48-hour telemetry due to changes found on his ECG. So that's for the patient and again for the GP to be aware of. In the allergy section, as you can see, I've included any allergies to medications. So this patient is allergic to penicillin. But as I said, it's important to list any reactions to any allergies, because some patients will say they have a mild rash to a certain medication, and that's not really an allergy. So that's why it's important to list the reaction to any medications as well. In the general comments, again, I say the gastro team will see this patient in 14 weeks' time. So I've included the time frame in my discharge summary. So the patient's aware that in 14 weeks' time, they will be seen by someone from the gastro team. And the GP is also aware in case they want to follow up on this. And in the management notes, I've said, again, mention about the gastro appointment and that they will be seen in clinic following PCI. In the information to give into the patient section, so that's when we talked about any safety netting for this patient or any information you've given verbally to this patient, but you want to write it in legal form or just to remind the patient. So I've told the patient, please seek medical advice if experiencing further chest pain or shortness of breath. So I've told this patient in my discharge summary what symptoms to watch out for. So yeah, this is the end of the example for this discharge summary. As this is a legal document, discharge summaries will need to be signed off as well. But a lot of the time, whoever gives the patient a discharge summary will sign it off. So it does not necessarily have to be you. It can be the nursing staff as well. but you'll have your name. Whoever prepares a discharge summary will have their name at the bottom of the discharge summary, written automatically with the software your hospitals will use, along with the responsible consultant in charge of this patient's care. Okay, so now we're going to go through other examples of discharge summaries. So we'll go through this example, and then I just want you guys to write in the chat if you think this is an example of a good or a bad discharge summary compared to the one I've showed you. So the one I've showed you is like a reference discharge summary, so a reference for a good discharge summary. So we're going to go through this one, and then you guys will have a chance to judge on your own if you think it's a good or bad one, and then Nihal will just tell me at the end what the majority of you guys think. So here we have a patient, a 72-year-old lady. So the reason for admission, the author of this discharge summary has written difficulty swallowing, so fair enough. So the symptoms this patient came up with. And in the diagnosis section, Nihal, can you see this slide now?
Hi, Hamza. Yeah, can you... which slide are you on? Are you on slide 8, is it?
Yeah, 8. Reason for admission is
I
difficulty swallowing. Can you see that?
I can't see it. Chat, can you see the slide?
Yeah, I can see it. Should I just...
Okay, yeah, there seems to be a general consensus they can see it. It might just be my screen. You carry on, Hamza.
All right, okay, yeah.
Okay, you carry on.
All right. Yeah, sorry about that. So, yeah, let's get back to this example of a discharge summary. So this one, a 72-year-old patient came in with difficulty swallowing. So the reason for admission, the author has written difficulty swallowing. The diagnosis, the author has written difficulty swallowing. So again, I don't think that's not really a diagnosis. That's more of a symptom. But we'll come back to this after. I'll let you guys decide on that. In terms of past medical history, the author goes on to list different medical conditions this patient has. So again, difficulty swallowing, asthma, cataract, hypertension, thoracotomy, lumbar disc, circumcision, and gout, and asbestos-related lung disease. So it doesn't really specify what type of lung disease, just says asbestos-related lung disease. The investigation section, where you'd usually include any blood tests or scans, is left empty. Procedures section, again, is left empty. So I don't know, maybe this patient didn't have any procedures done, but if empty, like I would write nil personally. So let's go on to the clinical features section. Let's see what this author has written. 72 years old patient, admitted with difficulty, pain in swallowing, ongoing SOB. So they've used an abbreviation. They've not really explained what this abbreviation is about. Again, the patient is not used to medical terminology. So if this patient is receiving a copy of this discharge summary, they might not understand what SOB means. They might think it's a swear word. Yeah. So patient had gastroscopy that showed esophagitis. He was started on fluconazole. So they've listed any medication this patient was started on and the management plan. To complete 7 days course. So again, there's grammatical mistakes. Lansoprazole BD. Patient doesn't know what BD means. So BD means twice a day for those of you who don't know. Biopsy was taken on OGD. So again, grammatical mistakes. OGD, not really explained to the patient what an OGD means. So these abbreviations such as SOB or OGD, your GP will understand it, but your patient won't understand it. Results will be chased by the gastro team. So it doesn't really say when the gastro team will see this patient. So what's the time frame in which they'll see this patient? So any allergies identified, no. So this patient's not allergic to any medications. Okay, fair enough. And any plan management notes. So on top they say the gastro team will review the results of the OGD, but here they say there's no follow-up plan at the end. So it's quite conflicting in terms of the information. Any information given to the patient. So they've said here, no information given to the patient. So they've not really safety netted this patient about any red flag symptoms to watch out for or who to contact. Yeah. So that's all. So that's this discharge summary. So I'll just give you guys maybe a minute or so just to write in the chat. Do you think this is an example of a good discharge summary or not? And then Nihal can tell me what you guys think in general. Nihal, are you there?
Hi, Hamza, I'm here. I think the general
Right.
consensus is it's a very, very poor discharge summary.
Yeah, you guys are right.
Yeah, I don't think anyone thinks it's very good. Chloe's mentioned that it's very poor compared to the example.
Yeah.
I think we can all see that.
Yeah, I agree with you guys. So let's move on to a few more examples. We have a few more examples to get through. Yeah. All right. Can you guys see this one? So this is another example of a discharge summary. The reason for admission is shortness of breath and tachycardia. So again, shortness of breath is not really explained. It's written out the abbreviation SOB and tachycardia. In terms of the diagnosis, so this patient, the diagnosis that was reached whilst in hospital was chronic liver disease, alcohol withdrawal, AKI. So they don't go on to explain what an AKI is. So your GP again will know what an AKI stands for, but your patient doesn't really know what an AKI means. They go on to list coexisting medical conditions, so their past medical history. This patient has esophagitis AF, fatty liver disease. Liver has been written twice, so fatty liver disease. In terms of investigation, so they do mention what investigations have been done whilst in hospital. So this patient had a CT head and an ultrasound abdomen and bloods taken whilst in hospital. But again, they failed to mention the results of these tests, but I assume they must all be normal. In the clinical feature, again, the procedures section has been left blank, and the clinical features section, we only have 2 sentences. So shortness of breath and tachycardia and alcohol excess. So I don't really understand what they mean there. I'm sure the patient or the GP won't really understand this discharge summary as well. And this is done automatically. So at our trust, if a patient has an AKI, it prompts you to review their medications. So this patient has an AKI, but as we can see, it's been resolved now on discharge, but they've not made any changes to any medications. They have asked the GP to repeat urea and electrolyte to check the EGFR in the community as well. But again, there's no formal documentation asking the GP to do those. So that's all about this discharge summary. So that's a very brief discharge summary, actually 2 lines, 5 words. Yeah. Do you guys think that's an example of a good discharge summary or a poor discharge summary? Again, put your answers in the chat and then Nihal will tell me what you guys think of in general.
Again, Hamza, I think the general consensus is that it's a very poor discharge summary.
Yeah.
Not much detail in there at all, is there? I don't even know what's going on, to be honest. So they're short of breath, tachycardic, and they've had a lot of alcohol. Well, that doesn't really explain anything.
Yeah, neither do I. I don't really understand what's going
Yeah,
on.
so
So
as a GP, I wouldn't be very happy with this. I'd
yeah,
probably email the consultant just to find out what's been going on with my patient.
I agree.
Yeah.
Okay, then let's move on to another example. Uh, so just bear in mind whilst writing discharge summaries, so we're critiquing discharge summaries, but bear in mind the situation you will be on when you are working on the wards. You won't have a lot of time. You'll have nurses asking you to write discharge summaries for multiple patients. You'll have other jobs to do, so you won't have a lot of time. So discharge summaries need to be concise. Uh, Again, the example I gave you is an example of a good discharge summary, but I don't think you will have as much time to write this much detail. But that having been said, so keep that in mind, and then we're just gonna judge this discharge summary. So in this one, we have a patient presenting with abdominal pain and vomiting, so reason for admission. The diagnosis, irritable bowel syndrome. And the author goes on to list the past medical history. So they give a good description of any past medical history. So this patient has menorrhagia, anxiety, depression, post-traumatic stress disorder. So they avoid using any abbreviations such as PTSD for the patient to understand as well. In the investigation section, they go on to list any relevant investigations. So this patient has not had any radiological scans, but they have had blood tests taken on admission. And the author does go on to say the results of these blood tests, even if it is normal, so nil significant in full blood count, urea, and electrolytes. Unfortunately, the procedures section has been left blank, but I assume this patient has not had any procedures. So let's go on to read the clinical features section. Miss P was admitted to hospital with abdominal pain and a 2-day history of vomiting. So again, very concise presenting complaint. It's not wordy, it's to the point and includes relevant symptoms. Ultrasound abdomen and pelvis was normal, so it goes on to list any imaging, radiological imaging that was done. Miss P was started on gentamicin, metronidazole, and amoxicillin for 2 days. So it tells the GP any the treatment this patient has received whilst in hospital. And the patient was reviewed by the gastroenterologist who started her on amitriptyline, 10 milligrams. So it states the dose of the medication and the frequency of it and how long she should take this medication for. So 12 to 18 months. So that's important for both the patient and the GP to be aware of for how long to take this medication. And it goes on to say at the end, she was medically safe for discharge. So that lets the GP know that the medical team that saw her were happy with her current state to be able to discharge her. In terms of the allergy section, they list any allergies to medication. So this patient is allergic to codeine and the reaction to any allergies. So the patient experiences vomiting whilst taking codeine. And in the plan management notes, this patient will not have any outpatient follow-up, so they say no follow-up. They go on to list amitriptyline, which should take this patient should take for 12 to 18 months for irritable bowel syndrome. And in terms of information given to the patient, they say above has been explained. So what they mean by that is they've explained the diagnosis to the patient and the medication they should take, so amitriptyline for 12 to 18 months. And they've safety netted the patient as well. They say if symptoms worsen or persist, please seek medical attention. So that would mean contacting your GP or 111. So they've safety netted this patient. So bear in mind, this is a brief discharge summary, and like that, whilst you will be on the wards, you'll be really busy. You won't have a lot of time. Do you guys think, in general, this is an example of a good discharge summary, or it's not that good? Again, post your comments in the chat about it. So what's the general consensus, Nihal? What are they thinking?
So, Hamza, the general consensus is that this is a very good discharge summary. I think we can all see that it's very detailed. It's given a good breakdown of the coexisting medical conditions. We know exactly what's happened with the patient.
Mm-hmm.
I think the management summary is very clear.
Yeah.
So we know that the patient's on amitriptyline, 10 milligrams once nightly for 12 to 18 months. And also, it's very important to safety net the patient, guys. So in discharge summaries, we always safety net our patients when discharging patients, and it's always good to write in the notes what you've said to the patient in terms of coming back in if symptoms persist or get worse, or specific symptoms to look out for.
Yeah, I agree with you, Nihal. I agree with you guys as well. This is an example of a good discharge summary. Whilst it's quite brief, um, it contains all the relevant information you need to know, and for the patient as well. So it doesn't have a lot of medical jargon, and it's a good summary both for the patient and for the GP. So the first example and this example are both uh, standards you guys should aim for. But then again, when you do start, so you will get used to it. Writing discharge summaries is a skill you pick up on the job. So at the start, you will take a lot of time writing your discharge summaries for patients, but then you will get used to it, and it's a skill you will learn as an F1 because you will be doing numerous discharge summaries as an F1. So my next slide is just about the TTO, so to take out. So just to give you guys a general idea of how it appears at the end of the discharge summary. In terms of TTO, you guys don't really need to write this down. Pharmacists will usually tweak any medications, or on your software yourself, you'll make any changes to medication, but then it will automatically come out like this. So it will have a section about any drugs started in hospital for the example of this patient, they've been started on furosemide 20 milligrams, so the dosage and how often to take it. So take one 20 milligram tablet daily at midday. So why it's important to have this much details is because the patient will receive a copy of this. So it will have instructions on when to take your medications and how often. Any cancelled pre-admission medication, so rivaroxaban was stopped. And the reason we've stopped is a stop due to bleeding risk, and you have information for the GP to consider restarting that if the patient's hematuria is controlled. And then in the pre-admission section is any medication this patient came into hospital with, which you've not changed on discharging them. So this patient's on bisoprolol, digoxin, doxazosin, furosemide, and a list of other medications and how often to take them. So that's just for your general knowledge about how TTOs will appear. But there's nothing much for you guys to know about changing them because this will be done automatically by your software where you write discharge summaries or by the pharmacist. So a brief summary about discharge summaries, which we've done. So discharge summaries should be concise and should only contain the relevant information. Concise both for the GP, because GP don't have all the time in the world to read a discharge summary. They just have a few minutes before each consultation to read the discharge summary, but also because it will help you. As an F1, you'll be really busy on the ward. You don't want to spend hours writing a discharge summary because you have other jobs to do as well. So it should be concise but contain the relevant information both for the patient and for the GP. Should be easy to understand, no grammatical mistakes as far as you can help it, and should include a clear management plan and any outpatient follow-up with the expected time frame. Again, as Nihal said, don't forget to safety net your patient, including any symptoms to watch out for and who to contact. So next, we're going to move on to the second part of our talk, which is specialty referrals. So by specialty referrals, I mean when you're working on a ward and you need to refer to different specialities such as cardiology, respiratory, or gastroenterology to get opinions or to get your patients transferred across to receive the proper care. So when referring to a specialty, it's important to know the reason why you're referring to this specialty. So usually as an F1, you're the most junior member of the team, and a lot of the time you won't be aware of you won't know why your consultant wants a referral done. That's why it's important to clarify with your consultant or your registrar why they want this patient referred. This will help you understand. This will also help you refer. So then, when explaining to the other specialty why you want their opinion, it's important to use the S-bar approach, which you guys would have learned in medical school. And I'll speak more about the S-bar later on, but I won't go into too much detail because you guys would have a wealth of experience about it, having been taught in medical school with your OSCEs and all. It's also important to have any relevant information at hand about this patient when referring. So these could include patient identifiable details, results of any blood tests or investigations, which this specialty would want to know. So usually it's a good idea to have, when referring, to have this patient's blood tests or scans on the system as you're making the referral, so you can quickly refer to in case you miss any information out. And after referring, it's important to document your referral and the outcome of your referral, whether your referral has been accepted, declined, or any advice they've given you, and to update your seniors about the outcome of the referral so they can change their management plan accordingly, or re-refer the patient themselves if it's been declined. So as I said, so S-bar, so it stands for situation. So when you call the relevant specialty, you tell them who you are. Hello, so for instance, I'll be like, hello, my name is Hamza. I'm an F1 working in the surgical department. The background, so the background about this patient. So Mrs. X is a 78-year-old lady who presented following a fall, and a urine culture showed a growth of E. coli, for instance. Assessment, so what did you find on assessing this patient? For instance, you can say this patient had suprapubic tenderness, and any recommendation, so what you think is going on, and what treatment plan you've started on as well. So for instance, you can say, us, the medical team, think this patient has a urinary tract infection, so we've started her on antibiotics for the urinary tract infection. So that's your S-bar. But I won't go on more to speak about it because you guys would have had experience about doing S-bars. But it's important just to practice your S-bars and to use this S-bar framework when referring to a specialty. Now you guys will ask yourself, how do you refer to different specialties? So again, this will be trust dependent. We have people watching this talk who will be going to different hospitals across the country. So different hospitals will do it differently. But also according to different specialties. For instance, for Nihal and I, we're both at the same hospital, but according to different specialties. So for some specialties, we do paper referrals. For others, we send emails to secretaries or to the relevant consultants. Or for some of them, we just call the on-call consultant at that time to get opinions or to refer this patient. So it will depend on your trust and on the specialty. But to find out more, you will get to know about it during your induction, or you'll learn about it as you start the job according to your trust. So it will be different according to different trusts. So I've just asked Nihal if he could kindly post the referral cheat sheet, which is available on the Mind the Bleep page. So I would prompt you guys to refer to this. So this is quite useful. But here I'm just going to go through some common specialties which you might be asked to refer to, and some useful information to have at hand when referring to these specialties. So when referring to cardiology, it's important to include in your referral any information about any ECGs this patient might have had, and comparing this ECG to any previous ECG. So, because the cardiologists want to know if there's any ECG changes. If you're referring a patient with chest pain and STEMI or STEMI, to have the troponin levels at hand. So that's the first and second troponin levels and the trend, whether the troponin is going up or it's going down. And any relevant symptoms such as chest pain, shortness of breath, or any pedal edema, which could suggest heart failure. If the patient has had any previous echoes, you can include this in your referral. And what did you hear on auscultating for heart sounds? Did you hear any murmur, or were there normal heart sounds? And it's also important to list to tell the referring clinician about any relevant past medical history if it's cardiac related. For instance, has this patient had an NSTEMI or STEMI in the past? Are they known to have heart failure, or are they known to have angina, for instance? If referring someone to respiratory, it's important to mention their oxygen saturation and their oxygen requirements. So, for instance, if someone has new onset oxygen requirements, it's important to let the consultant or registrar know when referring this patient across and how much oxygen they're requiring. So, for instance, you can say Mrs. X is needing 2 liters of oxygen and she's maintaining sats of 90% on those. Important to let them know about the baseline mobility of this patient as well. So this patient gets short of breath by walking across the room, or this patient gets short of breath by walking 2 blocks. So usually, what I mean by that is when the patient is well, how far are they able to walk before getting short of breath? If you're suspecting any chest infection, treating for chest infection, have you sent any sputum culture, and has the sensitivity come back yet? And it's also important to mention, to check on the system whether the patient has had any growth, microorganism growth in the past for any previous medical, for any previous hospital admission, because a lot of the time the patients will come in with the same they'll grow the same microorganisms which they have grown in the past, so that can be quite useful. When referring to respiratory, important to let them know of any radiological investigations you've done, such as chest X-ray or CT thorax, and what the findings are, whether there's any new findings, or even if it's clear, so they can have an accurate picture. Or if you've done an ABG, just to let them know of the results of this ABG. When referring to microbiology, the microbiologists might want to know about any inflammatory markers, so any blood tests, including white cell count, neutrophil count, CRP, are those raised, are they going down, and the trend in those. Any blood cultures taken, and has the blood culture grown anything? Any allergies to any antibiotics and any reaction to those. As we mentioned previously, some patients might say they're allergic to penicillin, but when you actually go ask them what happens when you take penicillin, they might be like, oh, I have a mild rash. So that's not really an anaphylactic reaction. So you could potentially give this patient penicillin if it comes to it. And any trust guidelines, it's important to know what the trust says about starting patients on what the guidelines say. So which antibiotics your trust wants you to start on for a relevant infection, before you speak to micro, just to make them aware that you've checked the guidance, that you're being proactive. If you're referring to neurosurgery or neurology, you might want to tell them about this patient's baseline functions. So before coming to hospital, for instance, is this patient usually fit and well, or are they wheelchair bound, or are they tetraplegic, for instance? The nature of the injury, if the patient has had an injury. So if the patient has had a road traffic accident and you're referring to neurosurgery, you want them to know how severe this accident was, so they can form a picture when you're referring this patient across. The GCS of this patient and the findings of any neuro observations. Again, the results of any radiological tests, so CT head or MRI reports, what does it show? Even if it's normal, I would simply mention it. Any medications this patient is on, so this could be relevant, for instance, if a patient has had a subarachnoid hemorrhage and they're on a DOAC, a blood thinner, so they might tell you to stop it. So that's why it's important to know about any medications this patient is on. And again, any past medical history or family history, so then they could be aware of any neurological conditions which run in the family, such as MS, for instance, or there's this this patient have a predisposability for stroke because they have a strong family history of stroke. When referring to surgery, the surgeons might want to know about the baseline function of this patient. So is this patient usually fit and well? The reason they want to know about this is so that they know, is this patient going to be fit? Are they going to be a candidate for surgery? Because if this patient is usually frail, they wouldn't tolerate general anesthesia very well. So hence they wouldn't be a candidate for surgery, and hence your surgeons wouldn't really accept these patients. Any relevant past surgical history, any operations they've had in the past, the blood tests, and any results of any radiological scans this patient has had. And lastly, any examination findings. So when examining the abdomen, what did you find? Or is this patient peritonitic, for instance? So it will help them decide the urgency of them having to assess this patient. A last example is referring to renal. So the renal team might want to know about any renal blood tests you've done. So the EGFR, the creatinine level, and is it rising or is it going down? The urine output of this patient. So are they oliguric, or how much urine have they passed in the last 24 hours? The fluid status of this patient. Do you think this patient appears dry or do they appear wet? Any scans which have been done, so ultrasound KUB is quite a useful one to have if it's been done. So this can potentially exclude some renal causes of AKI, for instance. Medication history for this patient, are they on any nephrotoxics and has this been withheld? And again, the baseline function of this patient. So the reason they might want to know this is, would this patient be a candidate for dialysis if they are considering it? So this has been quite a whiz through about some common specialities you could refer to. But again, I would point you to the direction of the Mind the Bleep cheat sheet referral page just to get a better idea. The next, I'm just going to run through a few examples of specialty referrals. So just so you guys can appreciate about how we would usually refer a patient. So we're going to pretend Nihal is the relevant consultant at the other end of the phone, and I'm an F1, and I'm going to refer a few of my patients to him to different specialities. So my first example is a respiratory patient. So I'm a surgical F1, as you can see, and this one I'm sending an email to Nihal. So this will be an email referral. Nihal is a respiratory consultant, and now I'm referring an 89-year-old lady. So as you guys can see from my email, I've included patient identifiable details, and I've said I would like a respiratory referral, please. So I'm referring an 89-year-old lady, and the reason I'm referring is for new onset oxygen requirement. I go on to list the relevant past medical history, so type 2 diabetes, peripheral vascular disease and iron deficiency anemia, and some blood tests and the trend in those. So this patient has a normal white cell count and a normal neutrophil count, but they have a raised CRP of 135, and it has actually gone up from 65 on admission. I go on to tell Nihal, who is the respiratory consultant, about the results of my examination. So on auscultating the chest, I heard bibasal crackles with no wheeze and no evidence of pitting edema. So this tells Nihal this is more likely a respiratory condition and not heart failure, because there's no signs of pitting edema. This patient has also gone to have a chest X-ray, which showed all changes in the left lung, but but increased opacification in the right lower and middle zones, and this patient is coughing up white phlegm. I then go on to tell Nihal about the impression. So I think this is hospital-acquired pneumonia, and I tell the respiratory team the management plan we've initiated, just so they're aware of. So we've started this patient on IV amoxicillin as per the trust guideline for hospital-acquired pneumonia. We've sent sputum culture, and we've also sent urinary antigen for Legionella and pneumococcal. We've started this patient on saline nebs 4 times a day as well. And then at the end, I just say, would be grateful if you could please review my patient. So this is an example of a respiratory referral I had put through by email. So the next example of a referral I'm going to put across to Nihal. So I'm going to pretend Nihal is from the cardiology team, and I'm going to refer him one of my patients to be transferred to the cardiology ward. So Nihal, are you there?
Hi, it's Nihal, the cardiology consultant.
Hi there. My name is Hamza. I'm one of the surgical F1s. I was just wondering whether you're free to talk so that I could just refer one of my patients who came in with a cardiology complication. Would that be okay with you?
Yeah, that's fine. Yeah.
Okay. Thank you. So I'm just referring Mr. X. Mr. X is a 70-year-old gentleman. He has a background of type 2 diabetes, hypercholesteremia, and angina, and had an NSTEMI in 2018 with 2 stents fitted to the left circumflex artery. So Mr. X came in with a 1-day history of sudden onset central crushing chest pain radiating down his left arm and his jaw. And the pain was relieved by morphine given by the paramedics, but it was not relieved by his GTN spray. Mr. X is hemodynamically stable at present. He has a blood pressure of 125/80 and a heart rate of 76. ECG showed new T-wave inversion in lead V2 to V4, and his troponins were 54 and 200 respectively, showing an upward trend taken 6 hours apart. So we, as part of the medical team, the medical clerking team, we've been treating Mr. X for ACS, so for NSTEMI. So we've started him on the ACS pathway, and we've started him on Fondaparinux as per the trust guidance. Is that all you wanted me to do for Mr. X? Would you agree with the current management plan? And if so, would you be happy to review Mr. X whenever you have time, just to check? Would that be okay with you?
Thank you, Hamza. Yeah, I think you've told me everything I need to know in that referral. That was a very thorough referral. So thank you, and I'll come and review Mr. X this afternoon after my clinic.
All right, thank you. All right, so here, that was an example of a referral to cardiology. And now, guys, we're just going to run through a last example. So I'm going to pretend Nihal is the on-call consultant microbiologist, and this time I'm referring. I'm going to do a referral just to ask for some advice on some antibiotics. Hello, is this the on-call microbiologist?
Hi, yes, it's Dr. Chanyan, the on-call microbiologist.
Hi, Dr. Chanyan. My name is Hamza. I'm one of the surgical F1s. I'm just calling with regards to advice for one of my patients today. Would that be okay with you if I just run it past you?
That's absolutely fine. Go ahead.
Okay, thank you. So I'm just calling with regards to Mrs. Dorothy Price, so hospital number 1234. And she's a 92-year-old lady with a history of recurrent UTI. She came in with her presenting complaint was fall, and she was found to be quite confused as well. On admission, she had raised inflammatory markers with a white cell count of 14.0 and a CRP of 79. Urine MCNS taken on admission showed a growth of Proteus mirabilis, sensitive to gentamicin and amoxicillin, but resistant to trimethoprim and nitrofurantoin. The reason I'm calling you today is because I just wanted your advice on any antibiotics I could start this patient on for their UTI. According to trust guidance and the sensitivity, it would have been gentamicin and followed by tazocin, given that they have a low EGFR and they're quite old as well. But unfortunately, given that this patient has an EGFR 45 and they're allergic to penicillin, I'm not quite sure what antibiotics I could start. And the allergy, which I have documented for in terms of penicillin, it says that this patient has quite a severe rash when they take penicillin. So I don't think it would be advisable to start them on any antibiotics which contain penicillin. So I just wanted some advice on any antibiotics you'd advise me starting this patient on and the duration. That's all right. Yeah.
Yes, Hamza, that's absolutely fine. What did
Yeah.
you say the EGFR of this patient was?
So the EGFR was 45, and the allergic.
45. Okay. Okay. And have you accessed the local trust guidelines?
Yes, we've accessed the local trust guidance. According to that, it would be tazocin with a stat dose of gentamicin. But unfortunately, I can't give tazocin as this patient is allergic to penicillin. So would you suggest maybe meropenem then?
Absolutely. I think meropenem would be our next best bet. It will cover all the bacterium that we are looking to kill. And yeah, essentially, if you start the patient on IV meropenem, let's say 400 milligrams TDS.
Yeah.
Yeah,
Sounds
400 milligrams TDS. And if you reculture the gentleman or the lady in a couple of days' time and let me know the results of those cultures, that would be great. Thank you very much, Hamza.
All right. Thank you, Dr. Chanyan. Thanks for your time. Bye.
No worries.
All right, guys. So these are 3 examples of referrals I've just put across. So as you can see, I've my S bar, but it has to be quite brief. You don't want to give too much information as well, because remember, at the other end of the phone or at the other end of this email, you have really busy consultants and registrar. They don't have all day. They just want to hear the relevant information, and you as well. You just want to find out what you can do for this patient, what they would advise you on. So next we go on to the last section of this talk, so requesting radiological tests. So this will include anything from chest X-ray to CTPAs to CT thorax. So when going to request radiological images, it's important to know the reason why you're requesting for these scans and the symptoms of your patients, because your radiologist might want to know why you want to do these scans, and how the results of these scans will change your management plan. So for instance, if you have a patient who has a pulmonary emboli and you've started them on treatment for pulmonary emboli, and it's now 1 week down the line, and you want to get a CTPA now, it wouldn't really be advisable because you've already gone down this line. You've already treated them for this. The results of this CTPA wouldn't really change your management plan. But for instance, if you're suspecting lower respiratory tract infection for a patient who has a new onset shortness of breath a few hours ago, a chest X-ray would be really useful because it would confirm your diagnosis of lower respiratory tract infection. So it's important to know why you're requesting these scans, the symptoms of your patients as well, and how the results of these scans will change your management plan. When requesting for radiological scans, important to note how urgent you want these scans. For instance, if your patient is critically unwell, you need to tell them, I want this chest X-ray as earliest as possible, please, because this patient is quite critically unwell and we're suspecting a respiratory cause. So this will help in our management plan. Or if it's something which can wait, for instance, if a patient is if it's an ultrasound scan which can wait a few days, then you can let them know about this as well, because they will be quite busy as well. If you are requesting for scans which involve like contrast or dyes, it's important to know the patient's last EGFR, because these contrasts and dyes can be detrimental to the patient's kidneys. And if requesting for an MRI to know if this patient has any metal work in place, so that will be any contraindication for an MRI. To note, if you're requesting for a CTPA, it's important to put on there the well score, which you can quite easily calculate using some apps such as MDCal, and the D-dimer, because this will make your referral like more genuine and will back it up, especially if they have a high well score and a raised D-dimer. So this will help get your scan accepted. And lastly, you should specify whether you want the scan portable or non-portable. In general, most of your scans will be non-portable, and the few exceptions will be for critically unwell patients who would require a portable chest X-ray because they cannot be moved to the radiological department due to their high oxygen demand. So usually for patients on 15 liters non-rebreathe mask, you can't really wheel them down to the radiological department. You'll need to get a portable chest X-ray. But for the majority of your patients, it will be non-portable scans. So they will have to be brought in by the porters to the radiological departments. So to summarize, throughout this talk, we've talked about the importance of discharge summaries. We've gone through examples of discharge summaries, so both good and bad, and you guys have had an opportunity to give your opinions about what you think about them. We've gone through specialty referrals, and lastly, it's important to practice. So I wouldn't be too overwhelmed by the amount of information I've given today, because a lot of these are things you'll learn on the job. But you guys, it's good that you've had this information and that you've attended this talk now, so it'll get you a bit more prepared for when you do start on the job. Just a reminder, if you have enjoyed this talk, we have other talks upcoming as part of our FY1 Survival Guide. So our next talk will be held by Dr. Pamela Sturge. So she'll be talking about organization skills and seeking support as an F1. So that's really important because F1, as an F1, it can be quite difficult and quite overwhelming having finished medical school. So it's important to know how to organize your jobs and how to seek support if you do need them. But then we have other talks about understanding the e-portfolio, some talks about pay and finances, and common bleep scenarios, and managing the deteriorating patient, which will be delivered by a medical registrar. So keep your eyes open for these. So I'll just redirect you guys to this barcode. So if you do scan this, you'll be able to fill out your feedback form. So your feedback forms, after filling those, you'll get a certificate which you can use for your non-core teaching hours as part of your F1. So then I'll pass you on back to Nihal, and we'll have a Q&A session about any questions you guys might have. So feel free to put any questions in the chat and we'll answer those.
Thank you very much for that insightful talk, Hamza. I certainly learned a lot, so I think it was definitely a good talk. And we'll just make sure that anyone who wants to ask any questions in the chat, go ahead and we can answer them.
The QR code is blurry, so should I just put it?
Don't worry. I can post a link to the feedback in the chat. That's
okay.
An issue. Just give me 1 second. And here we go.
That's great. Yeah, thank you, Nihal.
There's your link. It's very important, guys, that you give us feedback. Not only does it help us improve our webinars and give better teaching sessions, but also you get a certificate which you can use as part of your e-portfolio for F1. So this would count as a non-core teaching hour. And yeah, that's it's part of a large, let's say a large amount of work that goes into the portfolio. So every little bit helps. Okay, guys. Any questions about the talk? So any questions about referring to certain specialties, or any questions about writing a very good discharge letter? We can answer those now. I don't think there's any questions, Hamza. I think you've given that comprehensive of a talk that everyone knows exactly how to refer to the radiologists and the microbiologists, and they all know exactly how to write an excellent discharge letter. So we'll just give it another minute or so to see if anyone has any questions. But yeah, after that we can call it a day. Oh, here we go. Here's a question from Aftab Alam. Does it matter if a discharge letter is delayed, Hamza?
Yeah, so it does, because technically most of your patients won't be able to leave hospitals without a discharge letter. That's why as part of your F1, you often get nurses nagging you about oh, my patient needs a discharge summary, especially when you have a critically unwell patient. Nurses will consistently remind you that you need to write a discharge summary for their patient, because patients can't actually leave without a discharge summary. But that having been said, if your patient is usually fit and well, they can actually leave, and then you can post a discharge letter at the end. But for the majority of patients, they do need the discharge summary and the TTO, which I mentioned before they're able to leave. So that's for pharmacists to arrange for medications as well. That's mostly why they need the discharge summary and TTO. So your patient won't be able to leave the hospital. That's why it's really important to do your discharge summaries whenever you have time. Yeah, so it does matter if it's delayed. If it's delayed, this patient stays on the ward longer. They're not able to arrange transport, so the patient stays in for another day, and then it creates a backlog because A&E can't send new patients to the ward to replace this bed. Yeah.
Just to add to that, exactly, I agree with everything Hamza said. Discharge letters, ideally, they shouldn't be delayed. Normally, if you do a morning ward round, discharge letters will be the last thing you do in terms of your jobs. If you've got unwell patients, you need to prioritise. If you've got scans, you need to request. But it's always important that you finish all your discharge letters for the day so that those patients can get home to their families at a reasonable time, and so that new patients coming in from A&E can take the beds on the wards. Hamza, Ahmed Odotoro asks if there is any particular resource you can recommend. I'm assuming let's split it up into discharge letters and also for specialty referrals.
So for discharge letters, I'd say mostly learning through examples. I've not seen many resources available online. That's why I decided to include examples of discharge summaries I've seen in this talk. So refer to this talk, but they all mind the bleep and geeky medic pages on writing discharge summaries. Although, just to point out, the geeky medic article seemed a bit quite long, but it's mostly things you will learn on the job, discharge summary. So you learn through reading the discharge summaries of your other colleagues, and it's a skill both Nihal and I have learned whilst on the job. So it's a skill you perfect as you get along. In terms of specialty referral, so again, I would practice SBAR. So Mind the Bleep and Geeky Medics, they have useful pages on how to practice your SBAR, but that's about it really. And referring to that Mind the Bleep cheat sheet. But again, it's mostly learning on the job. I don't know whether you have anything to add to this, Nihal.
I agree. I think if you want to look into discharge summaries a bit more, you can reflect back on this video. We'll post it to the Medal page and also to the Mind the Bleep YouTube channel. You can just click pause on the good examples and read through and see, try and emulate that in your own work, essentially. And for specialty referrals, the best resource is the Mind the Bleep referral cheat sheet, which I've just posted a link to in the chat. Any more questions, guys? Or can we wrap it up and go and enjoy this lovely weather? We'll just give it another minute or so.
Yeah.
Anyone got any questions? I think that's it, Hamza. I think everyone's good. It was a very comprehensive talk, so I think you did cover everything. Should we call it a day?
Yeah, all right. Thank you, everyone. So I wish you guys all the best for your F1. And again, just remember, like both Nihal and I, we were in the same situation, but you learn on the job, and like I'm sure you guys will enjoy it.
Yeah, exactly, guys. You guys have got this far. You've gone through 5 or 6 years of medical school, passed your exams, very tough exams. You guys are prepared for this. I know it can seem daunting, having to speak to different specialists over the phone, but it's a skill you learn with time, and over time you'll get more comfortable with it, unless you're referring to certain radiologists that are grumpy. But yeah, we'll leave that talk for another day. Good luck, guys. I'm sure you can all do it. And yeah, well done for passing medical school.
And good luck. You're finally getting paid now, so you should look forward to it.
Exactly. Thanks, guys. Bye.
Thank you. Bye.